All right, so now we're going to continue talking about chapter 19, and we're going to focus mostly on our leukocytes and our thrombocytes, as well as some disorders with the blood. So when we're looking at leukocytes, leukocytes are going to be your white blood cells. Each person has some special antigens that are called your major histocompatibility antigens, or MHCs. These are surface proteins that are found on all of your body cells, and this includes your white blood cells. The whole point of these antigens are that they make you unique. Okay, so every person is going to have a different set of these, except for, of course, identical twins, because they come from the same egg that's fertilized by the same sperm. Now, the reason these are such a big deal is that they are very important in what we call tissue typing. When we want to do a transplant or see if somebody's a match, in that case, they are going to look at the histocompatibility test. This is where they're going to match the antigens as close as possible from the donor to the recipient. And so when they do this, this is why if they're a 99% match, then that's of course a better match than, say, a 92% match. And so we want to match them as close as possible to prevent your white blood cells from doing rejection of the organ or tissue that's being transplanted. Now, when we look at leukocytes, there are two kind of main groups that are the leukocytes. The first are called the granular cytes, or the granular leukocytes. These include eosinophils, basophils, and neutrophils. And the reasons that they're called granular leukocytes is based on their staining. When we stain these cells, they have what we call granules inside of them that you can actually see. And they look kind of like grains of sand, which we'll look at in a minute. On the other hand, we have the agranular leukocytes. When you add A in front of a word, it means not or without. They do not have cytoplasmic granules, and these include lymphocytes and monocytes. Monocytes, though, will differentiate when they go through the process of maturing into what we call macrophages. Now, macrophages can either be fixed, meaning that they stay in whatever tissue that they end up in, or they can be wandering, where they can move in and out of tissues, in and out of the blood, and so on. So in general, let's look at how a white blood cell works. Some white blood cells live months to years, but most will only live for a few days, especially if they're not going to be used, or they actually they sacrifice themselves to help protect you. Normal blood contains between 5,000 and 10,000 leukocytes per millimeter cubed of blood. When we look at this, if it's over 10,000, there's normally an infection that could be present. If it's less than 5,000, we could have some sort of immunodeficiency that's taking place. Now, the function of the white blood cell is to fight infections. Most of them do this by phagocytosis, where they're going to, almost like Pac-Man, they're going to eat the invader, take in the invader, and destroy it. However, some of them can also destroy the invader by producing antibodies. That's what the AB stands for. They produce antibodies which attack the invader. One thing I kind of talk about with the invader being attacked by antibodies, if you've ever seen the movie The Incredibles, I know it's a little older Disney movie, but there's one point where Mr. Incredible, his homing device from his wife gets turned on, and it sets off an alarm, and all these black like beads start being thrown at him that start attaching to him and slow him down until he can't move anymore. That's kind of how our antibodies work. They attach to the invader until the invader has been overcome or overpowered by the antibodies. There's also a number of other ways that they may function, but these are the two main ways, either through phagocytosis or antibody production. Now, white blood cells must leave the blood in order to do their job. They're going to do this through immigration. Now, if you'll notice, this immigration is spelled with an E. This means that they are exiting the blood vessel. Okay, so they are immigrating out of the blood vessel into the tissue where they may need to fight whatever the invader may be. When we look at this, the white blood cells are going to move through the blood vessels. They do kind of a rolling motion to stop on the blood vessel surface, and then they're going to squeeze through those tiny little spaces between cells of the blood vessel. Granulocytes and monocytes never return to the blood. Once they leave the blood, they cannot re-enter the blood. They're going to either stay in that tissue and die there, or they'll just remain there for the remainder of their time. Lymphocytes can go back and forth between the blood and the tissues. So they can go out into the tissue, complete their job, and then re-enter the blood, move to a new area, and so on. Now, a couple of terms that are important. The first one is leukocytosis. Leukocytosis is a general term that's given if you have a greater number of white blood cells. So if the white blood cell number is higher than 10,000, you would be diagnosed first with leukocytosis, and then they would be more specific of why that's happening. And a lot of times this is due to inflammation or some sort of infection. On the other hand, if your white blood cell count is less than normal, it's below 5, it's called leukopenia. So leukopenia means that it's lower than normal. It's less than 5,000 leukocytes. Now, in your book, there is a table. This is table 19.2. This shows you the different types of white blood cells. It gives you a picture with their name. It tells you what a high count might indicate, like what kind of infection or what kind of circumstance that you may see a high number of these, and then also in cases where you might see a low count of these different white blood cells. And this chart is found on page 674. So let's take a look at each of these white blood cells one by one. All three types of granular white blood cells have what we call a segmented nucleus, meaning their nucleus is kind of in multiple pieces. All right, it doesn't mean that they're completely separated, but they'll have segments to them. The first one are what we call the eosinophils. The eosinophils contain reddish orange granules in their cytoplasm, and you can kind of see it here in the picture. They have these kind of reddish orange granules, and if you'll see, they look like little grains of sand. If you'll see that the darker purple, that's its nucleus, and you can see that it's in two segments. Eosinophil granules contain what we call histaminase, and this is an antihistamine. Okay, so normally you hear about histamine. Histamine normally gets released during like an allergic reaction. These guys contain an antihistamine, kind of similar to like a Benadryl cream or a hydrocortisone cream. Now, the function of the eosinophils is to phagocytize antigen antibody complexes. So that AG is antigen, AB is antibody. So these are when antibodies attach to the antigen, the invader, they create a complex. This is then when eosinophils can come in and destroy that complex and get rid of the invader. They are also involved in allergic reactions, and they also are going to be in high number if they're there to fight parasites. High eosinophil counts normally are going to be seen in allergic reactions or parasitic infections. The next group we want to look at are the basophils. The basophils contain bluish purple granules. They are called mast cells once they move into the tissues. So once they move out of the blood into the tissues, we a lot of times call them mast cells. The granules contain heparin, histamine, and serotonin. So if you look here, you can see the little grains of sand, but you'll also notice that they are going to be bluish purple. They're darker in color. Now, the function in this case for basophils, they're involved in the inflammatory response. If you have a high basophil count, a lot of times it could also be due to an allergic reaction, but we also see this in certain types of leukemias. The next group are the neutrophils. The neutrophils are given a lot of different names. They can be called segs because their nucleus is segmented. They could be called PMNs, which is polymorphonuclei leukocytes, meaning that they have a lot of segments to their nucleus, or they could also be known as polys or bands. And you can see over here in the picture that this nucleus over here in the neutrophils in the darker bluish purple color, it has many segments. They contain pale lilac colored granules, so again, still the grain of sand, but they're more lilac, lighter purple colored. The function of the neutrophils are to actively do phagocytosis. They actively are like the Pac-Mans to eat and neutralize whatever the invader is. The big thing though is that we have to call them into the area. Whenever an invader comes in, we've got to get the neutrophils there, and this is through a process called chemotaxis. The injured cells, or the cells that come in contact with the invader, will actually release chemicals that attract or call these neutrophils to the area, and this is called chemotaxis. After chemotaxis, the neutrophils then are going to ingest the bacteria, the dead matter, whatever the problem is. Once they get the foreign object or the dead matter or whatever that they take into their cell, inside, digestive enzymes are going to be released by those granules, those lilac colored granules, and they're there to destroy whatever it consumed and took in. Some of the examples of these chemicals that they give off is lysozyme. They're going to help destroy bacteria, especially by destroying the bacterial cell wall. H2O2 sounds very familiar if you know that this is hydrogen peroxide. So it's just like hydrogen peroxide acts. We also see that we have O2 negative. This is a superoxide, which is a radical that can destroy the invader. And then we also have OCl, which is hypochlorite. So when we look at superoxide and those hypochlorite, it's very similar to what we call household bleach. That's there to help destroy the invader. Neutrophils also produce defensins. These are natural antibodies which punch holes in bacterial cell walls. If we can breach the cell wall, it's a lot easier to attack and destroy the bacteria because the wall normally offers the protection. A high neutrophil, or what we call a band count, could be due to a bacterial infection or, again, certain kinds of leukemia. Now we want to look at the agranular leukocytes. These are also called mononuclear leukocytes because their nucleus is going to be in one piece. Now you'll notice in this particular case for the monocytes or the macrophages that the nucleus can be in a kind of awkward or weird shape, and if you see here it's like a U or a horseshoe shape. Monocytes are called macrophages because they are very large cells. Their nucleus is normally kidney shaped or U-shaped. The cytoplasm is more of a blue-gray color. When a monocyte leaves the blood, it matures into what we call a macrophage. Some macrophages are fixed, meaning they're stationary and they stay in that one place that they're left. Other macrophages are going to be free to move between the different tissues into different areas. The function of macrophages are to actively do phagocytosis, just like neutrophils. Monocytes and macrophages are better against fungal infections, however, and also bacterial infections like tuberculosis. Neutrophils are better against most other bacterial infections, but against tuberculosis, macrophages are going to be better. Neutrophils reach the infection site first because they're normally smaller. Since they're smaller cells, they get there first. However, when the macrophages come in and are present, they actually can work faster and do more damage of getting rid of the invaders. So it's kind of like if ground troops go in and fight in a certain area, they can do some damage, but then if you drive the tank in there, it's going to take longer to get the tank in there, but the tank can do some major damage very quickly. This is kind of the difference between the neutrophils and the macrophages. Macrophages are also going to be there to help clean up any cellular debris from when cells, if they get destroyed based on a virus or they get damaged due to the bacteria that was there, these guys are going to clean up the area and get rid of all of the debris that could build up due to an infection or inflammation. The next group we're going to look at is the lymphocytes. Lymphocytes are the smallest white blood cells. They're oval and round, and they have a very dense nucleus. And if you'll notice, the nucleus takes up majority of the cell. The nucleus might be slightly indented, like you can see here. It also has a blue cytoplasm once stained. Most lymphocytes are in the lymphatic fluid, your spleen, your lymph nodes, your lungs, and your skin. There's actually not very many that should be found in the blood. There's three major types of lymphocytes. There's B-lymphs. These are going to produce antibodies. There's T-lymphs, which are going to attack invaders, especially things like viruses, transplanted cells, and some bacteria. And there's also natural killer cells. Natural killer cells are going to attack invaders, and they're also going to help us get rid of tumor cells. These guys actually help prevent cancer a lot of times as we're younger, but the more and more we're exposed to things that cause cancer, the less likely these are going to work as well. Now, all of the above lymphocytes may be involved in transfusion reactions. So whenever you have like a blood transfusion or tissue rejection, when a tissue comes in, or certain allergies, lymphocytes can all be part of this. If you have a high lymphocyte count, normally it's due to a viral infection. However, again, it could be due to certain types of leukemias. Now, one thing to note about all these white blood cells is we will spend a little bit more time talking about them when we get to the immune system chapter, which is focused in on chapter 22. Now, one thing that we can do when we do blood work, not only we saw in the last presentation, we can do blood work to see how many red blood cells you have, to see if you're anemic or something like that. When we take blood work, we can also do what we call a white blood cell differential, a WBC differential. This is a lab test which determines the percentage of each white blood cell that is present. This can help us with diagnosis, because earlier you saw that in some cases there's certain ones that fight fungal infections better, and others fight viral infections better, and others fight tuberculosis better. If those are higher in number, then it can help us in diagnosing what the underlying problem might be if certain white blood cell numbers are high. And this is what we're looking at when we talk about a white blood cell differential. All right, so now we're going to switch gears a little bit, and we're going to talk about thrombocytes. Now, thrombocytes are also known as platelets. When we look at the idea of needing more platelets, there's going to be a hormone that's called thrombopoietin that's going to be released. The thrombopoietin is then going to go and talk to the stem cells in the bone marrow and create what we call megakaryoplasts. These megakaryoplasts are going to mature into megakaryocytes, because remember, blast is an immature cell, the cyte is the more mature cell. These megakaryocytes then are going to break into smaller pieces. Each of the smaller pieces is called a platelet. And so each megakaryocyte can actually make between 2,000 and 3,000 platelets. Now, each thrombocyte has a membrane, so each of these platelets contains a membrane. They also contain some granules inside of them, as well as cytoplasm. So you're not going to see a nucleus or any kind of organelles here. They are a lot of times disc-shaped. The granules that they do contain, they contain clotting chemicals. The whole point of these is to have these clotting chemicals that start the process of clotting your blood when trauma has happened to a blood vessel, to prevent bleeding. Now, if the platelets have not been used because you haven't had any damage to a vein or artery or anything like that, or any bleeding, a lifespan of a platelet is only between 5 and 9 days. So they don't last for very long. Now, let's talk a little bit about how thrombocytes function. How do they do their job of stopping bleeding? When we talk about the stoppage of bleeding, this is called hemostasis. Now, don't get this confused with homeostasis. Homeostasis means that we're looking at the same status of something like temperature, pH, things like that. Anytime you see hemo, we're going to be talking about blood. So hemostasis is where we're stopping bleeding. There's a couple of steps that have to happen in order to stop the bleeding out of a blood vessel once it's been damaged. The first step is called vascular spasm. What happens is when the damaged area when the area of a artery or vein gets damaged, it causes a spasm to take place in that vessel. The spasm is a contraction of the circular smooth muscle, because they have circular smooth muscle. It's going to cause a contraction, and it's going to bring the two ends closer together, okay? Because we've damaged the vessel, it's opened up, we want to bring the two ends closer together. This is a reflex that starts when the pain receptors detect the tissue damage. Okay, so it's a reflex. It's not something you have to think about consciously, it just happens. These vascular spasms cause what we call the vasoconstriction. This can last minutes to hours depending on the severity of the damage. The whole point of pulling the two ends together, though, is to help reduce the blood loss. Okay, so we're not losing as much blood because we're making the space smaller that the blood has the ability to get out of. And we can see that here in this picture. Now, once we've done the vasospasm and we've brought the two ends close together, we now need to plug up the hole. This is called a platelet plug formation. This is where platelets are going to do what we call adhesion. Adhesion means that they're going to stick. They're going to stick to the wall of the blood vessel. Right, so if we're looking here in this particular picture, in number 1, you'll see that they'll start attaching to the wall of the vessel. Now, when the platelets do this, they are going to release some chemicals that are going to cause a type of reaction to take place. The platelets will actually start to become spiny, which you can see in picture number 2. When they become spiny, they release their granules, and these are those clotting chemicals that are going to start the process of creating a blood clot. This causes the platelets to do aggregation. Aggregation means that they start to stick to each other as well as be sticking to the wall of the vessel. The whole point of this is to create a plug. The plug will get bigger and bigger as it attaches and connects more platelets together so that it stops the bleeding. Okay, when we look at platelet aggregation, though, this can be inhibited by aspirin. Okay, also the vascular spasm of bringing the two ends together can actually be inhibited by aspirin. This is why a lot of times people who have issues with having blood clots form when they shouldn't. This is why they're put on something like aspirin. Now, when we look at this platelet plug formation, this is only a temporary plug, okay? And so this is going to be like when you cut yourself and you've been bleeding for a little bit, and it starts the idea of a clot on it, and it's that gooey substance that's there. If you remove that gooey substance, you just remove the platelet plug. So then since you remove the platelet plug, then you'll start bleeding again, all right? And so when we look at this, this is a more temporary repair until we can get to the next stage. The next stage is called the coagulation stage, and this is actually where we form the blood clot. The liquid portion of the unclotted blood is called plasma, but when the liquid portion of the blood clots, it's called serum. And the reason it's called this is because it uses all of its coagulation factors in order to get thick and sticky. When we look at a blood clot has a number of things located in it. It has cells, it has a fibrin mesh that is made out of those coagulation factors. So what that fibrin mesh does, if you'll see in the picture here, is it actually creates a type of net or web, and it's going to trap cells. It's not going to just trap platelets, it's not going to just trap white blood cells, it will also trap red blood cells, and this is what's going to help make the clot for us. Now, there are 3 stages when we look at clot formation. The first one we're going to look at here is the formation of what we call prothrombinase. This, when we talk about it being an enzyme, it's going to be the prothrombin activator. It's going to convert the prothrombin into what we call thrombin. The thrombin, though, is going to allow the conversion of soluble fibrinogen. Soluble fibrinogen means that it can travel through the blood without it being an issue. What it does is it converts this into an insoluble fibrin. The fibrin is what's shown here in the pictures in the yellow. The fibrin is no longer soluble in the water, and so it creates a type of net. Okay, it can't travel through the plasma of the blood anymore. Now, in order to do this, coagulation factors are really important. There are about 11 plasma proteins plus calcium, which act as these clotting factor or coagulation factors. It creates what we call a clotting cascade. Number 1 activates number 2, which activates number 3, and so on. Now, there's 2 ways that this can happen. There's what we call the extrinsic pathway. If we talk about it being the extrinsic, this is the outside pathway. This pathway only has a few steps, and it actually occurs very rapidly. A protein called tissue factor is going to leak into the blood and help the whole process of the coagulation take place. On the other hand, you have the intrinsic pathway. This one is a little more complex and it is slower to respond. However, it's going to happen and take place inside the blood vessel. So those endothelial cells that line the blood vessel and the phospholipids are going to release Y-activated platelets. And the whole point here is to activate those platelets so that we can continue to make that plug and catch more and more of the cells to actually create a clot. Now, these coagulation factors interact in a specific sequence, okay? They have to interact in that sequence. If we're missing one of them in the middle of the sequence, it stops. So it's kind of like that domino effect. If you set the dominoes up and they're equal distance and you press one, we should be able to knock all of them down. The problem is if you remove one of the dominoes and you press it, it's only going to go so far, and then the rest of the dominoes stand up. The same thing can happen here with blood clotting, okay? As long as all of them are present, the process can move smoothly. But if one of those coagulation factors gets removed or is not being made due to genetic issues or something like that, it causes the patient to have a hard time creating blood clots. Now, each coagulation factor has its own name and it also has its own Roman numeral. I'm not going to ask you to memorize these, but I do want to give you an example. So coagulation factor number 3 is called the tissue factor, and it's released from damaged cells. All right, and so this is just to give you an example. Now, there is a table that talks about each of these factors. It is found on page 679, and it's table 19.4. Now, let's kind of take a look at this in a picture form. This picture is also located in your book on page 678, and it's showing you on both sides here, you have the extrinsic pathway and the intrinsic pathway. So if you take a look at this, you can see that the extrinsic pathway is going to release tissue factor, then it's going to take in some calcium, and then it's going to activate our coagulation factor X or 10. This is then going to be activating number 5 with some more calcium and so on. On the intrinsic pathway, this is going to happen inside of the blood vessel. The damaged endothelial cells are going to expose the collagen fibers. This is going to catch the damaged platelets. The activated platelets are then going to do what we call make platelet phospholipids. This is going to activate factor number 7 with calcium, which will ultimately activate factor number 10 and so on. So if you'll notice, the pathways end up in the same place, they just do it in different ways, and the intrinsic pathway has more steps. Once we get to the point of activating the enzyme prothrombinase, we see that this enzyme is going to allow for a common pathway to take place. So it doesn't matter at this point whether we started with the intrinsic or the extrinsic pathway, we're now going to do the same exact job. So this prothrombinase is going to convert prothrombin into thrombin. Once thrombin is created, it's going to convert fibrogen into fibrin, and this is going to allow it to catch and capture more red blood cells and other cells in order to plug the hole more permanently until it is healed with mitosis. All right, so when we take a look at this, thrombosis is when a blood clot forms inside a blood vessel which has not been damaged. This is not a normal process. We should only be making blood clots when our blood vessels are damaged. So thrombosis is not something that should take place. Natural anticoagulants are not being efficient here. A lot of times if a blood clot starts to form in a vessel, we should have our own natural anticoagulants that break it apart so that it doesn't become a problem. Now, patients with increased risks of forming clots may receive an anticoagulate drug, so they may be on certain kind of medications, and you may have heard of some of these like heparin or warfarin. These are going to help decrease the body's ability to clot. Now, this can create a problem though. If a person is going to need to have surgery and they've been taking heparin or warfarin, they have to be careful because there could be a chance that they could bleed very easily and bleed out during a surgery, and so a lot of times a patient might be taken off of these drugs before certain surgeries take place. We also see then if a thrombosis, a blood clot does form and it actually moves, it actually gets knocked out of its current location, it's called an embolus. An embolus can be caused by a blood clot, which of course is a thrombosis. However, an embolus can also be caused by an air bubble, a fat globule. A fat globule could come from a broken bone that hasn't been stabilized, because you remember yellow bone marrow has a lot of fat in it that could get released to the blood, or also from debris that gets released into the bloodstream. So any of these could be considered an embolus. An embolus may lodge into a specific tissue. Once it lodges into a specific tissue, that's where it normally gets its name. So you might hear of somebody who had a pulmonary embolism. This means that a blood clot got lodged in their lungs, because pulmonary means lung. You may have a cerebral embolism. Cerebral means the brain or head, and this is where it travels up there, and this is a lot of times what we would call a stroke. Now, what happens is this embolus is going to end up blocking the supply of blood to the tissues on the other side. It's like kinking the water hose. Okay, when you kink the water hose, you can feel the pressure of the water on this side by the faucet, but the other side is not getting the water because you've kinked the hose. This is kind of what happens with an embolus. It blocks that hose so that the blood cannot continue to flow through. Now, another thing that deals with blood when we're talking about clotting is hemophilia. Hemophilia is a genetic disorder. There's several different types due to some deficiencies in different types of coagulation factors, like different dominoes that have been removed from the sequence. Individuals who have hemophilia are considered free bleeders. This means that they can bleed for a very long time over a very simple or non-severe cut or injury. If a person has hemophilia A, they are actually missing or have a low level of factor number 8. If if they're diagnosed with hemophilia B, they have a low or deficient amount of factor 9. And then if they have hemophilia C, they have a lower or deficient amount of factor 11. Now, when we talk about normal coagulation, it's important to note that the coagulation molecules and factors are super important, but so is a vitamin, which is vitamin K. Vitamin K is required for the synthesis of those coagulation factors, especially factors 1, 7, 9, and 10. Okay, so if those don't get made because we didn't get enough vitamin K into our body, then we will see a problem as well with our blood clotting. Now, Coumadin, guys, Coumadin is another common anticoagulant. It's different than heparin and warfarin because it's considered what we call a blood thinner, and it creates a vitamin K deficiency. So in other words, even though you might be taking in vitamin K, it fools the body into thinking that you're not getting enough. And so because of that, it does not allow for us to make the factors 2, 7, 9, and 10 in the amounts that we need in order for coagulation to take place. Now, once the healing process has taken place and the blood vessel has responded and has healed, we see that there's going to be a clot retraction. This is a tightening of the blood clot, and it shrinks the blood clot as it goes. A lot of times this happens when you've had like an injury and you have a scab like on your arm or your leg or something like that, and it starts to kind of pull and get tight and it's starting to get smaller. That's the clot retraction phase. If you pull that clot off, even though it may be hard like a scab, it could open up the blood vessel again and the process has to start over. We also see that in this process of the retraction, there's what we call fibrin lysis. Fibrin lysis is the dissolving of the clot. The body will do this naturally. Sometimes we induce fibrin lysis artificially when somebody has a stroke. This is to help dissolve those thrombosis very quickly. However, it's only going to work in a certain time period. This synthetic or artificial form of the fibrinolysis is called what we call streptokinase. Now, hemostasis is very important. Again, the stoppage of blood, and this shows you the coagulation factors 1 through 14. It tells you their name, their source of where they're made. If you'll notice, majority of these are going to be made in the liver and released from there. And it also tells you what pathway it's part of. Is it part of the extrinsic part of the pathway, the intrinsic? Is it in the common pathway where the two merge together and it continues, or is it in all of the different pathways? This just gives you a summary. Again, I'm not going to have you memorize these different types of coagulation factors, but you should have a good idea and know that most of them come from the liver. All right, so when we are looking at blood work, a lot of times they're going to do a total or a complete blood count. When they do a complete blood count, or what we call a CBC, they're going to be screening for a number of things. First, they can look at the red blood cells and they can screen for anemia. They also can look for various types of infections if your white blood cells are too high. So what a CBC does is it counts red blood cells, white blood cells, and platelets per microliter of whole blood. We also can use this blood to run what we call a hematocrit. This is where we're going to see the percentage of red blood cells. We can also do a differential white blood cell count where we run the blood through, and we can be thankful for machines in this case, because to do a differential white blood cell count before is you'd have to do a blood smear on a slide, and you'd have to look through the microscope, and you'd have to go through and count each of the white blood cells that you see, and it would have like a ticker that you hit of what you see. Now we can actually run this through a machine, since they all look a little bit different and have some different structures, and the machine can count the white blood cells for us and give us that differentiation between the different types. We also see that a complete blood count will show us what our hemoglobin levels are, which is also related to anemia. Now what I want to talk to you about real quick is what we call blood typing or blood grouping. Red blood cells contain surface proteins. These surface proteins are called blood group antigens, and they are genetically determined. These are genetically determined from birth, and they cannot be changed. The plasma, which is the fluid of your blood, can contain antibodies that go against the other antigens, the ones that you don't have on your red blood cells. So let's just take a look at this picture first. This picture is found on page 681 in your book. So if you look at a person who has type A blood, they actually have the A antigen on their blood. You can see it kind of here as a purple circle. If they have A blood, they may contain an antibody against B, which you can see down right below it. For type B blood, you can see that the type B contains the B antigens. These are the turquoise looking colors that are kind of in a triangle. But you'll also see that they contain the antibody against A. Now this means that a person with A blood cannot receive B blood. If they receive B blood, their body will destroy the B cells because it's foreign. It doesn't belong there. And the same thing can happen if somebody who has B blood gets A blood. It will be destroyed. On the other hand, you can see type AB. AB has both the A and B antigens, so it has the purple and the turquoise on its red blood cell. However, there are no antibodies because they have both A and B. Type AB blood are the universal getters. They can get blood from somebody else who has AB. They can get blood from somebody who has A. They can get blood from somebody who has B. And they can also get blood from somebody who has O. Type O, guys, is like the recessive, okay, when we look at it. The type O blood doesn't have A or B antigens on it. If you notice, it has no antigens in this particular picture. However, because it has no antigens, it can have the antibody against A and B, which means type O is the universal donor. Type O blood can go to any type. It can go to A, B, or AB. Right? However, somebody who has type O blood can only receive type O blood. All right, so when we're looking at this blood type system, it's an ABO system. The A and B antigens on the red blood cells determines a person's blood type. The plasma contains the antibodies that are directed against whatever antigen is not present on your red blood cells. Now, the percentage of population with each blood type is shown in a chart that I'll show you coming up next. It's Exhibit 19.5. One thing to note, the universal donor is group O and the universal recipient or getter is group AB. Now, this is a very generalized look at blood, guys. There's actually a lot more protein markers that determine the blood that you can receive and that sort of thing. So this is actually very simplified and it can be a little bit misleading. There's other proteins to consider and they are named in kind of groups. It's called the Lewis, the Kell, the Kidd, and the Duffy systems. These are really important in women who are pregnant. A lot of times when they do their blood tests, they're going to check for these to make sure that there's not going to be a chance of them attacking these particular antigens attacking the baby. All right, and so these are some different tests that can be run also on blood. In your book on table 19.5, it shows you blood groups and blood types in the United States. It shows you O, A, B, AB, and an RH positive. It also breaks it down on if it's European descent, African descent, Korean, Japanese, Chinese, or Native American. And so you can kind of take a look at this to see how the distribution of blood types are. Also, you'll see in your textbook on table 19.6, it gives you a summary about how ABO blood groups work. And so if you look here with the A blood, if somebody has A blood, they have the A antigen on their red blood cells, which means that they can contain the antibody against B. What kind of blood can somebody with A blood get? They can get either A blood from somebody else who has A, or they can get O blood. They cannot, however, get B blood or AB blood. So this is a very helpful chart in you being able to see what antigens are present on each blood cell, what antibodies they may contain within the plasma or the liquid of the blood, who they can receive blood from, and who they cannot receive blood from. Now, why is this important? This is important because if you are given the wrong blood, it can cause a lot of issues. It can cause what we call hemolysis, where your immune system starts attacking the blood that's been put in that's foreign to you, and it starts breaking it into pieces, and the person then becomes anemic again, but then it can also cause some other damage. Another reason why this is so important is not necessarily the A, B, and O side. You've always heard of people, when you say, well, what's your blood type? They may say A positive or B negative. The negative and positive is referring to the Rh group in this system. Rh positive individuals contain the Rh antigen on their red blood cells. That means they have the marker for it. However, if you're Rh negative, you do not contain the marker for this particular protein. Now, one thing to note is you will only produce antibodies against Rh after your body sees the antigen. So if I was A negative blood and they gave me A positive blood and my immune system saw the Rh positive part of it, then my body would mount a response and create antibodies now against that positive. All right, so it actually has to see it before we have the antibodies in the system. Now, one reason we know this is due to blood transfusions, but also pregnancy. Now, if you look at this picture in the pregnancy, you can see during the first pregnancy that the woman carried an Rh positive baby, even though she was Rh negative. However, during childbirth, there is some mixing of blood that takes place from mother to child. So some of the child's blood actually gets into the mother's system. If the mother's immune system actually sees this and then creates its own defense against that particular blood cell that came from the baby, then they are going to contain those antibodies and they can cross the placenta. So if they get pregnant with another Rh positive baby, their antibodies are going to go in and kill the child before it can be born. This is called hemolytic disease of the newborn, or HDN. So if a mother is Rh negative and the baby is Rh positive, the mother may produce antibodies against the baby. The first baby is usually not affected because remember we talked about that it actually has to see it for the first time. So with the first baby, that's the first time it's seeing it, and so normally they're fine. The second and future children, though, that are Rh positive are going to be in danger of being affected by the immune system. Now, hemolytic disease of the newborn can cause what we call hemolysis. Hemolysis is where the red blood cells rupture, they break apart. Because this happens, the baby can become anemic. It also can have jaundice because we see that, remember that in red blood cells they contain that heme. That heme is a waste product, and if we're not getting it to the liver and kidneys because it's just traveling through the body exploding, it can cause the child to have jaundice. It can cause mental retardation, and it can even cause death of the baby. Now, can we prevent HDN? We actually can. A woman who is Rh negative, a lot of times they don't even test the baby to see the blood type of the baby yet. But what they do is they give the individual what we call a RhoGAM shot. RhoGAM shots are going to allow the mother to borrow the antibodies. And so those antibodies then kill off the blood cells that got mixed from the baby before the mom's immune system actually sees the problem. All right, so it's borrowed, it takes care of the problem, neutralizes it, and then they're gone. And so then the second pregnancy the mom has is like it was the first one because her immune system never saw the problem of the baby cells. Now, this brings us to why we need to look at blood types. With blood types, guys, the whole point is that knowledge of blood types is very important for things like blood transfusions. It's important to know in an ER situation during trauma session, you'll notice they don't sit there and look and say, okay, well, let's take a blood test real quick and see what blood type they are. No, if they have O blood available, that's what they're going to give that individual because remember the O blood is the universal donor. We also can use blood types of proving or disproving paternity because it's like using a Punnett square. We can also use this as linking suspects to a crime, and we also see that anthropologists will actually use this idea of blood typing because there's sometimes in the bone marrow because sometimes in the bones they find there is some bone marrow and they can trace and see what kind of blood type those individuals had in different areas of the world. Now, in a blood transfusion, let's just say you had to have a blood transfusion. If the recipient receives the wrong blood type, okay, I'm A positive. Let's just say that they gave me B positive blood. What's going to happen is in my body, there's going to be an antigen antibody reaction. This is going to happen very quickly, and we're going to see it's going to cause the destruction of the red blood cell, which is called hemolysis. So it's actually going to take the red blood cells and start breaking them apart and killing them because of this. Wrong blood types can cause the patient to develop a fever. They can develop a serious renal failure because their kidneys are having to work in overdrive, and it can also cause the patient to go into shock. So if we look here at this particular picture, it shows you that you have your red blood cells. In this particular case, there's the surface antigens. You'll see there that the opposing antibodies are present, and if you were to get those red blood cells that you shouldn't get, that have the blue spikes because they don't match yours, these opposing antibodies are going to attach to them, and they're going to rip those red blood cells apart. Once they rip the red blood cells apart, that's called hemolysis. Right? Well, now those red blood cells can't do their job. They can't carry oxygen, but also there's going to be debris in the area that needs to be cleaned up. So the last thing I want to kind of talk to you about, but it's also very important that you read about them in your book on page 683 through 685, are some disorders or imbalances when we talk about blood in the cardiovascular system. The first is anemia. This is oxygen carrying capacity of the red blood cells is reduced. Now this could be due to a low number of red blood cells, or it could be also due to hemoglobin deficiency. If there was a mutation in the protein that actually makes hemoglobin, we could see that this could cause them to have a hard time transporting that iron and creating more of the red blood cells that we need. There's different types of anemia. There's iron deficiency, there's pernicious, there's hemorrhagic, there's hemolytic, there's thalassemia, and also aplastic. In your textbook, take a look at how each of these is just a little bit different. It can be different based on how big or small the cells are, what's missing. Like in the first one, iron's obviously missing. Hemorrhagic is where they're bursting. Hemorrhagic is when you're bleeding. Hemolytic is when the cells are bursting, and so there's a lot of different types of anemia. We also see another disorder that deals with the blood is sickle cell disease. This is an inherited disorder due to an abnormal kind of hemoglobin. This hemoglobin doesn't give that disc shape to the red blood cell that's like a donut without the middle poked out. It actually gives it more of a sickle shape, which is like a crescent moon. All right, this makes it where it can't carry oxygen as well, but also as it tries to fit through those little capillary structures, now it has a sharp edge because of the crescent moon, and it can get caught. This can create clots and ultimately cause organ damage. So if we take a look here, you can see a normal red blood cell, you can see a sickle cell, and you can also see one that's crenated or shriveled up and shrunk up of red blood cells. Now, hemophilia, we also already talked about. This is an inherited, though, deficiency of clotting. It is a bleeding disorder. It's going to be, it's a bleeding disorder, so even from like a simple cut, they could potentially die from it just because their blood does not clot the same as most people. We also see there's different types of leukemia. We see acute leukemia. This is more of a malignant disease. Acute leukemia comes on fast and it spreads fast. This is uncontrolled production and accumulation of mature leukocytes. On the other hand, we have what we call chronic leukemia. Chronic leukemia is an accumulation of mature leukocytes in the bloodstream, and this happens slowly over time. Okay, so this could be over years before the leukemia is actually detected and can become a problem. We also see thrombocytopenia. This is decreased level of platelets. So anytime you see penia there, it means decreased number. Well, thrombocyte means that it's decreased platelets. If you have decreased platelets, of course, you're going to have a decreased ability to create blood clots. The last one's what we call pancytopenia. This is decreased levels of all blood cells. So this is where your red blood cells, white blood cells, and platelets are all going to be low. This could indicate that there is a problem with the bone marrow because all three of these come from stem cells that are located in the bone marrow. All right, so please make sure that you read your textbook. Also pay very close attention to the homeostatic imbalances found on page 683 to 685. This completes the look at chapter 19 with blood. So again, if you have any questions or concerns, please feel free to contact me.